All right, I wanted to start today, if the computer will cooperate, by just kind of looking ahead to the end of the semester. Because it sounds crazy, but there's only like a month and a little bit till we're done for the semester. So I want to make sure we're all on the same page. So I'm going to go ahead and share screen for our Zoom people. And pull up our syllabus. Maybe we'll give it a second. You can do it, computer. There we go. All right. So your next quiz is our next class. It's Tuesday. I'll do the same thing I did last time. I'll go ahead and put it in Blackboard. Y'all can bring in your laptops, like most of you have today, or do it on your phone. And then as soon as everybody's done, we'll dive into the next piece of things. So we'll be working on psychiatric disorders and learning disabilities. So next week is a little bit of a whirlwind, like 2 topics we're just gonna kind of brush over, because those are always topics that are popular for group projects. So I always kind of brush over them, because I know they'll both filled in more lately. There's one group that still hasn't met with me, so make sure y'all do that soon. And a week from today, each group, or by a week from today, you could do it today if you wanted. Each group should send me an article. So what this article is about is you want it to be just like a clear introduction to your group's topic. It will be, I like it to be like 10 pages of text or less if possible. If you need more than that, just let me know. If the references go beyond that, that's totally cool. But this is for your classmates to read before your presentation so they can engage with you more. It's also something that can be referenced for those questions on the final exam. So think of it as the equivalent of either the KNW or the Ogden readings for class, essentially, but you're providing it. So this could be like a book chapter. I know there's one group at least that's thinking of doing like a case study. That's cool. Or it can be just like an article that's overviewing what this disorder or your topic is. So again, a lot of what I've been telling the groups is put yourself in the shoes of someone who doesn't know your topic, right? What would be helpful to them to have a good background for your presentation, and then also to help them study going forward. So again, yeah, try to get that to me by next Thursday, particularly the groups that are going before Thanksgiving. Because that's coming up. Yeah.
I don't remember if these questions are even asked, but I know you said you want our presentations to be of a certain length. Is it okay if we have like a really quick video in our presentation?
Oh, definitely. Yep. Yeah. Like obviously don't make the video 25 minutes and you talk for 5. But yeah, essentially you can replicate anything I do in class or come up with more creative ideas. Yeah. So showing videos is great, especially to illustrate, what it might be like for someone who's living with that disorder or brain scan technology with it or anything along those lines. Yeah, that's a great idea. So then a week from Tuesday, you'll actually have a group project work day. We can talk about it, next Thursday, see what will work best for y'all. I was planning to come in and be here in person if people needed that. But if people would rather be scattered around campus, I can also do it remotely, right? And y'all can just sign on to Zoom with any questions you have. But it's just a day for your group to get together. You can use that time to practice, or you use that time to like put the finishing touches on your PowerPoint. Or if your group's a little more behind, right, you can start working on the PowerPoint, right? Whatever you need that time for. I wanted to give that to you this year. And then our group presentations will start on the 18th and continue the 23rd. So the 23rd is the day before Thanksgiving break starts. So I'm just gonna ask that I know that Thanksgiving break has a creep, just like any break, and people are like, I'm leaving Monday. If at all possible, please be here so your classmates have someone to present to. Just again, common courtesy, and it will help you for the exams, right? And then there's one more day of group presentations. After Thanksgiving break, it's a little weird scheduling wise because what would be our first class back after Thanksgiving break is port day. So professors aren't allowed to schedule classes that day. So, and then our last day of class will be the honors presentations. You won't be quizzed on these, but they might like reinforce some of the other information you've learned this half of the semester. So definitely plan to be here, be attentive. And then your final is from the midterm to now. So it's everything on quiz 3, quiz 5, and then, toward the end of the semester. Questions about the schedule, logistics, everything coming up. Again, you're like, Dr. Myers, it's so long. It's really not, right? What's today, the 4th? Yeah. And our final is on the 9th of December. So it's really not that long. Fortunately or unfortunately, however you look at it, right? Yay, we'll get a break, but I'm sure you all, like me, have a lot to get done between now and then, right? Okay. Questions, comments? Cool. Well, I think that the case study that y'all read for today is pretty darn interesting. So I'm just gonna have you all work through it. So probably be the last one we work through for the semester, unless I just don't feel like talking next week. Usually I'm like, I fill up those days, if that makes sense. So I'll come around and kind of assign you to little pods to do sections. And Amanda and Emily, I'll come back and give you an assignment as well. All right, so let's have one of these. Sure. Yeah, you just want to like chill. That's fine. So we'll have y'all do. Sorry, mix it up a little. And then do the testing results and I'm going to do this 2 seconds just because they won't be very long. The impact of the sign the first section to our online section. All right, so if anyone needs a refresher, this is Ogden chapter 19. And so my Zoom people, y'all are going to do identifying information and background and history. I'll throw that in the chat just in case I'm too muffled. So. And it's chapter 19 in Ogden. And I'm going to open up a breakout room so y'all can talk without being broadcast over everybody else. Stop share here. Okay, and I have it set for 15 minutes. I don't know if you'll need that long or not, but I can always bring you back early. Okay. Feel free to come on up and write up your question.
Oh, nice, good. Okay, cool.
You know, I would have to compare her earlier edition of the book to that one to see if they're all the same or if she's putting new case studies. Probably the late 90s. Just like 15 minutes. Yeah, we'll get out early that day, or we can do some time reviewing. I don't feel like I'm gonna be super sad to get out early, the day before finals thing, so. No. I love by the way that just like coffee and water has been here for what, like 3 weeks now? I'm just like, I don't want to open that coffee room. I wonder what's growing in there now. Next Tuesday, there's supposed to be another event in the city that will probably have that same setup, so they'll get a pleasant surprise from everybody. All right, I'm gonna, oh, it's gonna be, hang on, I gotta turn down this volume. I'm gonna try something where I use this to actually show you all what people are writing on the board as they're talking. So we'll see how it works. I mean, I don't know how great my phone camera is, so I don't know how good it'll be, but.
Let's see if that works better. That'll probably work better. Oh, now you can hear me over the speaker. That's not creepy. Alrighty. So while our last folks are finishing writing stuff, sorry, you guys are gonna hear an echo. Why don't we have our online group go first because they did identifying info and symptoms, whatever comes first. Background. There we go. And I'm gonna mute.
All right. So, all right. So for her identifying info, her name's Kate. She's 45 years old and she's a female. Her background, she worked full-time in a large city library. She had an uncomplicated birth and normal development until she fell from her cot and hit her head, causing right hemiplasia. She was left-handed because of her right hemispheric damage. And all of it was interesting because all her siblings are right-handed and she turned out to be left-handed. She had an active social life. She attended a special school until completing 8th grade. She didn't have many friends when she was younger. She lives independently now that she's older and has been married and divorced. She's outgoing and sociable, and she holds many strong opinions on a variety of topics that she likes to talk about, like with her peers.
I love that. You gotta love someone with very strong opinions. So, all right, I'm gonna walk on over here and switch my camera. Ta-da! And have the group walk us through symptoms.
Grades that it's difficult to manage school, aggressive room.
Yeah, so I mean, here's a case that's kind of like HM in some ways, right? Like consistent problematic seizures, and how do we help this person have a livable life? Already testing results and diagnosis.
And comprehension. During the WAIS score would increase for a while and then ended up declining after a while. The RAY complex figure test, which is visual spatial perception, planning, and construction, showed an impairment when she was given the test. At age 51, her memory quotient was assessed using the WMS, and her memory quotient had actually decreased. On the differential aptitude test, she scored a 3 out of 10, while most adults score between 7 and 10. And she had mild neglect of the right side and normal recognition of familiar faces, but had difficulty recognizing some of the same faces that were photographed under different lighting. She had good emotional tone and speech that was appropriate in the situations that were given to her. And then the diagnosis is that she was
Correct. So they took out an entire hemisphere of her brain, if you can imagine. All right. impact on life and family, and then treatment. Sure, so just like someone with a stroke, right? The opposite side doesn't have as much responsiveness. All right, and what they do for treatment. Excellent. Sorry, I'm going to sign off.
All right, hopefully that was helpful for those of you on Zoom, so you could actually see what was on the board. You know, it only took me the whole semester to figure out that hack, but you know, it's fine. Yeah, so again, here's someone that the seizures are so debilitating, they've wrecked her brain so much, right? That the best solution for her doctors was, we're gonna take out half the brain, right? And she really is a really nice case of brain plasticity and recovery of her function, right? Because as our testing results pointed out, it wasn't perfect, right? Like she did lose some functionality, as we would expect, losing half your brain, right? But as your chapter pointed out, and had some nice diagrams of this, right? Her brain kind of rewired itself in certain ways, and she was able to do many, many functions, right? So I think that that is something that surprises people, very similar to the Gabby Giffords case, right? Like, here's someone who, like, you would think should have died, right, as a result of that. But in fact, there are times where it's doable and where you can actually keep living, and she lived a pretty decent life, right, afterwards. So she had friends, she held a job, she got married, she advocated for herself in medical situations. I know there's a lot of us who have our full brains that struggle with that sometimes. I've been watching, it's a couple weeks old now, but the documentary that Allie Raisman did for Lifetime, where she goes around and she's talking to other survivors of sexual trauma. And one of the things they talk about is like how important it is to try to figure out ways to live, right? And figure out ways to do all of these things and advocate for yourself if your trauma was medically related. How do you get yourself to go to the doctor when you know you need to, that type of thing. Excellent job. Okay, good. Amanda says it was helpful, and so does Macy. So huzzah! Experiment. Excellent. All righty. So the first thing before we dive into things is just a little plug. This is unusual for us, so we're kind of surprised by it, but several of our upper level classes for psychology are maybe not going to fill and not going to make. That's super weird for us. Like usually we have wait lists for them. So I'm just putting a plug in for those classes. If you might have like dismissed them or said like, oh, I won't get in. So industrial organizational psychology with Dr. Jackson, if you're thinking of going into like HR or working in a business setting, really great class. IO psychologists make the most out of any practicing psychologists, so no one there. Psych with gender as of right now made, but I would always love more people. We do some really fun stuff in there, talk about a lot of really cool intersectional topics. The one that I'm really going to push just because I don't know if it's going to make is clinical psych, which is my one that usually has the longest wait list. It's a nice complement to this class, if anyone's able to fit it into your schedule. So we learn about all the different types of therapy, and we learn about what clinical or counseling psychologists actually do. I have a lot of guest speakers who come in who are practicing. So if you're thinking at all, like, I might want to be a clinical or counseling psychologist or a social worker, this is a really nice class to take for that. I think some people might be scared away because it's a W. But it's like the paper builds over the course of the semester. So you turn in small chunks and then you just put it together at the end. So it's not as bad as it sounds, I promise. So yeah, I mean, obviously none of you have to take it, but if you're interested in it and it fits your schedule, or this is something now that you'd rather take rather than something you signed up for, please let me know. And if you're a sophomore, I'm glad to sign you into it.
So what if that says when will we find out? Because I need to find out.
Right, we should find out in January. I think I only need I need 3 more for it to actually make 2 more. So we could get 2 more people. Tell your friends. I've also heard there are people who just haven't registered. So if you just haven't registered, register. Consider this class. And some of our other upper levels, like history and systems, fulfills the requirement for the new major, for example. But yeah, I can also argue that because it's a W, people need it to graduate. And so then I might be able to talk them into letting you run it even under enrollment. So I've done that in the past, and we've done that with other classes. So I love teaching it, so like I want to teach it. Oh, a W is if you're kind of in the transition between old to new general studies or general education, you used to be required to take writing classes, which are W's. Now the Wesleyan seminars have sort of replaced them. So like I think Groove came under the catalog where that's the system. But some people are still sort of in this in between until they still have to, I think it's either after this year or next year, the W's are just not going to exist anymore. I mean, the classic will exist, they just won't have W's on them anymore. So yeah, so there is writing, but honestly, not that much more writing than my other classes. Y'all are used to writing a decent amount for me, right? So anyway, that's my plug. I just love for it to make, or I'll advocate for it. But yeah, we do have seats. And if you just have friends that you think might be interested who aren't even psych majors, send them our way for these upper. This is just so weird for us because we're such a popular major. I've never seen this happen before. What's that? Every other spring, and then I've been occasionally teaching it online as well.
One of my other classes is the same time slot, but I think that one's offered more than that.
It might be, if it's something like cognition, it might be offered every year. I think that's often about the same amount of time. Yeah, Dr. Slipka and I really should have coordinated because both those count for the WGF major. That's our bad. That's like lesson learned for the future. So, but yeah, so that's my plug. Thanks for indulging me in this advertisement. I did not talk about guns or abortion at least. I mean, if you've been watching anything with ads, that's what they've all been about for the election. So, all righty. We got a chat here as well. What is that class? So that's Psych 354. And one of the classes I signed up for next semester is showing on the screen right now. It says 0 students have signed up for it. Oh, that's interesting. Is it possible that, so maybe the system isn't checked correctly, or sometimes it says there's 0 seats. So that might be what's going on, Macy. So that class might actually be full, for example. Yeah, so I think that's probably what happened. But yeah, so just a plug, tell your friends to register. It's how we do planning. But yeah, they should give me till January to figure out. And like I said, I can advocate that people need the W to graduate. So. Alrighty. I have a couple.
Well, in New Zealand.
Other little videos, nothing as long as the Gabby Douglas one we watched the other day, that we'll watch to talk about recovery of function. And then I have just a few bullet points I want to make sure we cover from the SGA that we haven't gotten to yet. And then you'll probably get out a little early today. We'll see. Maybe we'll get really into things and that won't be the case. Alrighty, so this first one is about whether the brain can heal itself, which is we're learning probably a possibility.
Well, in New Zealand, there are about 50,000 people living with the experience of having a stroke, and there are 5,000 new strokes each year. It's a leading cause of adult disability worldwide. The consequences of stroke can be a temporary disability or requiring long-term care and a complete loss of independence. So this has an enormous social cost.
Well, a stroke is when part of the brain loses its blood supply due to a blockage or a leak, and the cells in that area start to die within minutes. No two strokes are alike. The effects depend on which part of the brain has been affected, and recovery depends on the ability of the surviving parts of the brain to take over those functions that have been lost.
The new biomarkers we're developing now are based on magnetic resonance imaging techniques and also magnetic stimulation techniques. Both of these tell us both the areas of the brain that have been affected and are also still capable of contributing to recovery. By finding ways of making the brain more responsive to therapy, we're hoping to improve people's capacity for recovery and shorten their recovery times.
At the Centre for Brain Research, we're investigating a number of ways to prime the brain for the best possible response to therapy, and these include non-invasive brain stimulation, different medications, and different movement patterns.
So priming increases the activity in the stroke-affected side of the brain and then makes the brain more prepared for subsequent therapy, and that therapy would be the more traditional rehabilitation involving such things as physiotherapy and occupational therapy.
I'm just going to pause real quick because you've heard me talk about the Groove Pegboard before. This is what they're doing right now. So it's they have to put these pegs in a certain order, and they're kind of shaped so they only go in the hole one way. So it's sort of hard to describe unless you see someone doing it. And so good to know that.
With our research, ultimately we'd like to put better tools in the hands of clinicians and therapists so that they can help their patients get back to as normal a life as possible after stroke.
This is the cool thing about research and clinical psychology in general, but clinical neuropsychology in particular, is a lot of the research is about treatments and what's the best way to make treatments more effective, make treatments more relevant for people. So the conference that I attend and present at each year is the Association for Behavioral and Cognitive Therapies. And it's always looking at like, how can we tweak these therapies to make them the most helpful to people with certain disorders. They've also done really cool research on just like how psychotherapy will actually change the brain, like especially people with depression. They actually see changes in the HPA axis in people who undergo therapy, especially cognitive behavioral therapy, which is very cool. All right, and then I have one other. Oh yeah, go ahead.
They're showing us something outside. Is that TMS?
It probably is TMS. If you don't know what TMS is, it's transcranial magnetic stimulation. And it's sort of a less traumatic way of doing ECT or electroconvulsive therapy in some ways that kind of works the same way in the brain. So it's a big magnet and they can kind of like aim it at the skull and where they think the issues are. And these sessions of just like having this magnet aimed at your skull, you do it short amounts of time. There we go. Or like sometimes daily for a few weeks. And then it can show really dramatic improvement, again, without like having to do electroconvulsive therapy and like make someone have a seizure, basically. So yes, very cool. So that's another really cool thing we can do for recovery of function for people, particularly with depression, anxiety, things like that. All right. One thing we don't talk about a ton in this class, simply because my PhD is in adult psychopathology, is kiddos. And so I wanted to include a video showing how we might help a kiddo recover. Because obviously you might need to explain things, do things in different ways that actually are gonna make sense, right, to that small person.
My name is Ben Tadrak and I'm 8 years old. I like to play soccer and I like to play basketball. I like eating chicken tenders and fries.
As I always say to people that never met him, I said, if you could start with him, you'd have 10. He's that delightful a kid. He always has been. He's got the best disposition.
That's a good one. He's such a fun little boy. He's just pretty vivacious, loves sports. He's sweet. He's really kind, just really playful, just an absolute darling little guy.
When Ben Sawchuk came into the pediatric ICU at Hopkins, he came in as a head injury. He was riding his bike and got hit by a car, and he was critically ill. He was one of the sickest brain injured patients that we have seen. He came in a coma, so it was not medication induced. That was the injury, the severe injury to the brain, put him in a coma.
You don't know when somebody's in this type of a coma whether they will come out of it or not. You don't know if they do survive, what return of function will there be? Will they be able to walk? Will they be able to talk? Will they be able to feed themselves? Will they be able to remember anything? Will they be able to interact?
Dr. Kristen Nelson, she was amazing. She stayed round the clock with him because, as she said, you know, Ben needed me last night.
You really just have to monitor things and do things very frequently, because if you don't, the swelling and the injury in the brain can get worse. And it's that first 48 hours that's really critical.
And it was obvious to me that she wasn't sleeping. She was sitting there fixing this. And that's very clearly the reason why he survived.
We say they kind of checked their egos at the door because it was all about Ben and it was all about his life and his survival, and they worked amazing hours and they were very dedicated to him, and I can't say enough about them. I mean, they saved his life. After about 3.5, 4 weeks at Hopkins, he was released to start receiving therapies. And for the last 4 or 5 months here in Baltimore, he's received amazing therapy and continues to make progress daily. They got him back on a bike very soon after his accident. It's a different type of bicycle, and he's been riding, I'd say, every week since he started his therapies. It's the favorite part of his day.
Because of our really positive experience that we had with the Johns Hopkins Children's Center, we said, you know what, they've got to see the magic that they had a hand in, right? And the miracle of, you know, this kid. So we brought him back there.
Hi, you look so great.
To see him and the staff, the nurses that took care of him 24/7, the doctors who, you know, really were worried that he actually might not make it, but does. And to see their reaction, it was an amazing experience for them and for us.
That's one of the benefits of working here, is you get to work on a team where excellence is a pursuit.
We have the ability to do some other things that other hospitals.
So now they're gonna basically do a ad for Hopkins, which we don't necessarily need to see. So it is a great medical center. They have a history of some problematic things, like Henrietta Lacks. But yeah, so you could see that, I'm gonna actually stop sharing now too. You can see that, you know, doing those types of therapy every day, kind of similar to Gabby Gifford's, you know, physical therapy. They're probably doing speech therapy with him, occupational therapy. All those things are so vital. And then they also might be working on training him in, you know, memory, things like that. I mean, when someone whose brain is still developing, right, as this happens, that becomes a real challenge, because you want to reduce as much as possible, as quickly as possible, any potential effects on that developing brain, right? And so that's why they talked about, I mean, early intervention is so important, right? I'm gonna blank on her name, but like the woman who got hit by the garage door, right? And like her intake was kind of delayed, right? She was just kind of like, oh no, it's fine at home. You know, if she had been seen a little earlier, it's possible like her recovery would have been a little better. So this is true of things like stroke as well, heart attack. So I mean, my recommendation is, if you're ever in question after something like this, like seek medical care. Yeah, try it. Well, thank God they finally did it, and thank you for advocating for him. That's overwhelming, right? Like, it's amazing how much things like that get missed or skipped over, not followed up on, and it can be really tragic. So I'm glad in this case, it sounds like you were able to get this client some help, which is excellent. Yeah, I mean, getting, and a lot of people don't like going to the doctor or worry about the cost, things like that. I mean, I can relate. I've had times in my life where I'm like, do I want to pay another freaking copay? Right. But like, just to give you guys an example, I've been really open about the fact that I had postpartum depression and anxiety, just because I feel like if I talk about it, people might feel more comfortable maybe seeking help themselves. And like, the first step essentially before you get a referral is typically to go back to your OB, and your OB is a specialist, and so I could have a $50 copay, and I was like, do I really need to pay that? And like, my husband and kind of other people convinced me to go, and I'm so glad, because it really changed the course of my life after that, to get on medication, to find a therapist, things along those lines. So, you know, that $50 was probably the $50 I spent best ever, right? And like, I don't think I was ever quite that bad, but certainly saved my quality of life if it didn't save my life, right? And certainly the quality of my husband and my daughter's life as well. I think the cat was fine either way. So I think that that is, you know, really important to look at. So yeah, just a couple points on here that I want to cover. And then, like I said, you'll probably end up finishing a little early today. So one of the things that Kolb and Wishaw talk about is the distinction between compensating for an injury and fully recovering from it. And the analogy they use I like is it's like a three-legged cat or dog. If you've ever seen an animal that's missing a limb, they can get around really great, right? They can often run and play and have sort of adapted, but they're never going to regrow that limb, right? Which would truly be recovery. But they can compensate for it. And so most changes after brain damage are essentially compensation. It's other areas of the brain learning to sort of reroute around the damaged area of the brain rather than recovery of those missing brain areas, right? So like Gabby Gifford's, not the Olympic gymnast. Gabby Gifford's parts of her brain that were affected, especially, you know, her speech centers, didn't regrow, right? Certainly that healed somewhat, but essentially she was able to kind of program around them, right? Using especially the right side of her brain. And so, you know, maybe someday we'll come up with ways to stimulate that regrowth more, or, you know, I don't know, we'll ever have like little brain implants we can put it. I just like imagine the future of medicine and how like we have no idea what we'll be able to do, right? Like things that we do now that people in the 1800s would have been like, what witchcraft, right? Like I'm sure there's something like that 10, 50 years down the road. Okay, so recovery from a couple different areas that Kolb and Wishaw focus on here. One is motor cortex damage. So something like hemiplegia, your reflexes tend to return first, and then you'll develop some rigidity, and then you start to sort of fill in what was sort of facilitated by other movements. And especially if we're thinking just like hand movements, grasping. And then you're able to voluntarily grasp things like the other, you know, essentially instead of just like your arm telling your hand, go here and grasp things, or sometimes even physically having to move it, right? You can do it yourself. And complete recovery occurs in almost a third of patients with this type of problem, 30%. And they can happen pretty rapidly, so 23 to 40 days. Again, that means 70% of people are not gonna have complete recovery, right? And so that's something to always keep in mind, you know, for every case like Gabby Giffords, there are unfortunately numerous cases of gunshot wound victims who don't make it, right? And I think that's always important to keep in mind. Aphasia. So people who develop aphasia as the result of head injuries actually show the most rapid and most complete recovery, especially if they're closed head injuries. Deficits are least severe, in anomic patients, and most severe, maybe not surprisingly, in people with global aphasia, right? If all your areas of functioning are affected, it's going to take more to recover. However, the rate of recovery, like how quickly you recover, will be about the same regardless of the type of aphasia. Kind of similar to motor cortex damage, most of the recovery happens at the beginning, so the first 3 months. Again, maybe not surprisingly, we tend to find in this case or in general, younger patients recover better. That video we just watched of Ben, the young boy, is a nice example of that, right? Often you're just like healthier, more optimistic, vibrant, right? So that can help. And the language areas in the right hemisphere, so those that essentially Gabby was able to access as she went through recovery, are the most resistant to damage. So that's good news for trying to help rewire, right, those things. Lesions are also talked about in your book. So these would be areas of damage on the brain. We do see variable recovery after brain injuries that cause lesions. So for example, it varies from 4% for motor deficits to 24% for people with dysphagia, to 43% for people who have visual problems. So if we're looking at the occipital lobe. However, about half of people who do suffer some sort of lesion on their brain have no level of recovery. So they still can function, but not anywhere near their pre-injury level. Now, we do know that there are times where, you know, our case study today, right, was an extreme example of how to treat seizures, right? Let's take out one whole hemisphere. But there are surgeries, there are brain surgeries you can do to address that, right? That would be much less invasive, much less dramatic. So sometimes they'll be able to pinpoint the area of the brain, a smaller area of the brain that is seeming to be most related to the seizures, and they can go in and surgically damage it, purposefully lesion it to try to account for the seizures, to try to stop the seizures. And so your recovery of functioning from those surgically placed lesions actually seems very dependent on where in the brain they have to be made. So for example, dorsolateral frontal lesions, they just never recover the ability to do like the Wisconsin card sort test, which is like a pretty good indicator, sort of higher level indicator of executive functioning and decision making and impulse control. If you have right temporal lesions, you don't get recovery on the right figure, right? Kind of similar to our person today who still struggles with the right figure. Obviously, if you have to do something like HM, where you're bilaterally removing big chunks of the brain, right? Recovery is going to be pretty questionable, maybe no recovery at all. But if there are left temporal lesions, this one is weird to me. You do see significant improvement, but it's time delayed. So often you don't see the improvement until 5 years later, or even 20 years later. And I don't know if it's just it takes that long to reprogram or what it is. But yeah, the brain is still a mystery in a lot of ways, right? There's still a lot we don't know about the brain and why things work the way they work. So what variables can affect recovery? We already talked about age. Younger patients tend to have quicker and more recovery. When you look at something just like employment as a measure of recovery, there is about an 80% recovery rate. Now, you may have been someone who was like a lawyer and now you're working at a grocery store, right? So it's recovery of function because you're working, but it's not the same level, right? So we kind of have to keep that in mind. We do see that social relationships and leisure activities suffer. It can be really hard for other people to understand what's going on with you. So measures of recovery often overlook like the coping mechanisms the person is using and whether those are adaptive or not, right? You can be recovered and feel like you're doing well socially, but you're dependent on alcohol and you never were before in social situations, right? So we kind of always have to keep that in mind. Females seem to have more bilateral activation and more recovery. I doubt very much that this is biological, because I know other studies have looked at this and just found that because women are often asked to handle more things at once, whether it's like childcare or, you know, work and home stuff, or just doing extra stuff. Like my WGS class this week talked about office housework. They read an article called Madam CEO, Go Get Me a Coffee, about how like no matter how high up in the organizations they are, women are often asked to do more of like the menial tasks around the office. So I would guess that that's learned, right? And if you're left-handed, because our world is set up for right-handed people, people who are left-handed are less lateralized. So they're less dependent on their left hand because there are some tasks they have to use their right hand for. You're driving in America, right? You're changing anything on your heating or your radio. You got to use your right hand, right? Because that's where it is. So that seems to be an advantage for recruiting those undamaged regions to help sort of rewire after injury. People of higher intelligence tend to have better recovery. Again, I don't know that that's biologically. We know that intelligence test scores related, among other things, to your socioeconomic status, right? Having access to really good education. So if you have a high socioeconomic status, you also have access to really good care, right? So I think that's part of it. And then, as we saw again with the kiddo Ben, we have optimism, extroversion, and being easygoing, leading to better recovery. And I wonder how much of this is receptiveness of the people working with you, right? Like it's just easier to work with someone who's like optimistic and happy. And so that might help. Movement therapy, as we've seen, very important. It actually stimulates plasticity in the brain, those changes. Cognitive rehabilitation would be where neuropsychologists would really be involved. So you come up with like substitution systems, you help them kind of retrain their brain. We talked about TMS, brain stimulation, and it's promising without the complications we see with like ECT. So some of the complications of electroconvulsive therapy can be memory loss, which like if you're trying to help someone recover functioning, not that helpful, right? And other things as well. Medications, particularly like steroids and things that help with inflammation. And again, we're thinking maybe down the road, we might be able to do stem cell transplants or maybe even brain tissue transplants, although those are fairly early. All right, we didn't end up finishing that early because I just was like, got really into things. So, but you got 3 minutes. So Tuesday quiz. And then we're gonna start talking about some of the psychiatric disorders and how those are linked to brain diseases. So things like schizophrenia, for example. Alrighty, thanks Zoom people for signing on, and have a good weekend if I don't see you tomorrow. Yeah.
If I share my presentation.